I have to give you one more little tidbit. There's one other study on adherence that I think is sort of funny. There was a study where they asked psychiatrists, how often are your patients taking their medications consistently? How often are they non-adherent to treatment? And the psychiatrists estimated about 6% of their patients were non-adherent to treatment. Then they asked the same patients of those same doctors, and 44% of them endorsed that they were not taking their medicine consistently. People lie, people lie, they do, and they're certainly going to lie often to their psychiatrist. So let's talk about how to conceptualize, how to think about bipolar disorder in a very global way, but we're using a cognitive behavioral type of framework. So let's assume for a second that the episode of depression or mania sort of starts a cycle. And I'm going to assume that it starts a cycle because we know that these episodes can occur spontaneously. They don't necessarily need to have a precipitant. They can pop up. A person can suddenly begin an episode of depression or an episode of mania. But we know that there's these episodes that begin. And one of the first things we notice when someone is entering an episode of depression or mania is that they have changes in their thought process, or changes in their cognition, and also changes in their emotions. And those cognitive changes can be of a variety of sorts. They could be slowed thinking, they could be negative thinking and depression, they can be racing thoughts and mania. And that those changes in cognition inevitably lead to a change in behavior. So if they're strong enough, how you think differently and how you feel emotionally will affect actions. And those actions can lead to a decline in psychosocial functioning. So for example, if I'm depressed and I'm oversleeping, then I'm going to be late for work. And so I start to have job problems. That might be my decreased psychosocial functioning. Oh, did that arrow just appear out of nowhere? Boy, it's magical. Okay, I didn't do that. It's really cool, but I didn't do it. All right, so once functioning has declined over a long enough time period, it's not unusual for problems. Let's see if it works. Zoop. Oh, look at that. Psychosocial problems will develop. And that might mean a loss of a job, or having to drop out of school, or losing your home because you couldn't keep up with your bills. Something big happens, and then the cycle perpetuates with those problems making symptoms worse. People lose sleep because they're worried about their problems, or that stress tends to exacerbate the symptoms, and that perpetuates the cycle. So we go back to the top of having depression and mania continue. Does that make sense to you? So the symptoms build, they make functioning worse, that creates problems, and the having stress makes the illness worse, and so it tends to cycle. So that model makes sense? Go like this. Does that model make sense? Yeah, okay, good. The goal of this intervention is then to try to break the cycle, or to stop it at each point in its evolution. So if we think about traditional pharmacotherapy, let's see if the arrow works again. We might focus at the very top again, and we're trying to, there it goes, that worked. We might try to actually address our medication at stopping an episode of depression or stopping an episode of mania, like stopping the symptoms there. Or we might actually have the intervention be just to the left of that diagram, to the left, there you go, that way, there you go, to prevent the next episode from occurring. It might be more of a prophylactic or preventive treatment. You're trying to prevent the recurrence from happening, and that's really the focus of pharmacotherapy. But when you're treating people in psychotherapy who have this illness, they're going to come to you at a variety of places on this cycle. So you want to be able to provide them with skills that can help to break the cycle regardless of where they are in terms of the evolution of that episode. The overall big picture goal of CBT for bipolar disorder is relapse prevention. That's where we're heading. So this is different than traditional cognitive therapy for major depression, where the goal overall there is to eliminate an episode. Typically when you do CBT for depression, you're going to treat the episode's going to be over, right? And then you're going to taper off treatment, and you're going to end treatment. And then that person might come back at some other point in time if they got depressed again. Same thing with anxiety disorders. You're going to treat them for 12, 20 sessions, somewhere around there. For their anxiety disorder, you're going to fix them, and then they're going to leave your practice because they're all better. Right? That's kind of generally how this works. In bipolar disorder, it's a very different model, because there is no such thing as cure or the episode being gone. You might have a time of remission between episodes, but that doesn't mean that treatment stops. So the medication treatment continues, and the need to be vigilant of symptoms and to be able to catch problems before they evolve into a full episode, that still continues. So you might actually, in practice, see somebody for, let's say, 12 to 20 visits if you have that flexibility with your treatment insurance coverage or whatever else. Let's say you treat them acutely, and you're teaching them skills to manage their illness overall, and the skills that we'll be talking about these next couple of days. And then you're going to be trying to help them out of the episode, and then their goal is to continue on being vigilant and monitoring, using those skills you've taught them to prevent episodes from occurring. Then if they have a recurrence of their mania or depression, they begin to have a recurrence, they then recontact you or resume regular visits with you to try to stop the episode before it becomes a full relapse. So I might treat somebody, let's say, off and on for 6 months, and then I might monitor them like once a month, may see them once a month, and if they're doing fine, maybe once every 2 or 3 months. And then if they begin to have a recurrence, they'll call and say, I think it's coming back. And so on the phone, I will initially say, okay, what are you supposed to do? What do you know to do to prevent your depression from blossoming or from your mania from continuing? Let's do those things, and then I will schedule to see them as quickly as I can. And then our focus will be on putting into place practices, including tightening up their medication adherence. But the goal being to prevent that episode from continuing or from growing into a full relapse. That also might mean that I'm using that time to talk with them, with their psychiatrist as well. So I try to communicate openly with their treatment, the person who's providing their meds, which is usually a psychiatrist. And we're able to talk about, okay, this person's already having difficulty sleeping. We know that if they don't sleep well enough, they're going to get manic based on their history and based on what's common in this illness. So what can you give them medicine-wise to help them sleep tonight? So the doctor might call in some PRN sleeping meds or may give instructions to increase one of the medications that might facilitate sleep. And that way we don't have that recurrence. We can stop that potential recurrence of mania. So again, the bigger picture is helping people over the long haul of their life have fewer episodes, or when they have them, for them to be shorter in duration than previous. So the model is very different than other cognitive